clinical and nursing practice with direct responsibilities in inpatient care, case management, social services, and education. Kathy serves as the organization's Magnet Program Director and facilities, structures, and processes to support the professional practice environment and quality outcomes. Kathy, thank you so much for being willing to share today, and I'm going to turn it over to you.
Thank you, Jennifer. Can you hear me okay still, Jennifer?
Yep, and then I have control of the slides, so if you want to just tell me when next slide, and I will do it for you.
Okay, that sounds great. Thank you.
All right, thank you.
Thank you for having me today. I'm happy to be able to share a little bit about our journey here at Waverly Health Center. And we're going to focus today, I'm going to focus on our experience with kind of a response to all of a sudden a trend of increased falls with injury, and share a little bit kind of in a case study in a way of ways we changed our practices in identifying risk and prevention. So you can go to the next slide, Jennifer. So for today, we'll talk a little bit about our process here at Waverly Health Center. What do we do for quality data and monitoring our falls? Well, how do we analyze falls? And from that, talk a little bit about risk identification, how we addressed that and made some changes. And so we've really done a lot of action plans around trying to reduce unassisted falls and falls with injury. And then we'll share a little bit about our outcomes and our journey here so far. So you can go to the next slide, Jennifer. So a little bit about Waverly Health Center. We are a 25-bed critical access hospital. We, on our med surge, just to kind of give you a sense for volume, we have average daily census of about 9. We have about 260 births a year and a little over 7,000 ED visits a year. We do have 9 clinics. Some are on-site at our facility and some off-site in surrounding communities. And in 2014, we were recognized by the American Nurses Credentialing Center as a Magnet organization. So we're the first independent critical access hospital to achieve that recognition. And since 2009, we've been designated as a Plaintree hospital. Plaintree is an organization that supports patient-centered philosophies of care, and so we obtained designation showing that we met their components of patient and family-centered care and have been able to maintain that. So that just tells you a little bit about us and where we're at. We're in Northeast Iowa in Waverly, Iowa. Next slide, please. So here at Waverly Health Center, for quality data related to falls, we do submit our fall data along with other clinical and process indicators to a national database. So what we report our total falls. We also get reports related to our falls with injury, so we're reporting our injury level for each fall. We're reporting also assisted and unassisted falls. We also report process indicators, and so those, when we get our reports back, really can help us look into things like risk assessment. Was risk assessment done appropriately? Are we identifying people that have fallen as being a fall risk? And it helps us look at prevention interventions. Are we appropriately putting prevention interventions in place for those that are at risk of fall or that have fallen? So that we submit to the National Database of Nursing Quality Indicators for that. Next slide, please. So how we manage that data then after we do kind of assign some of our quality indicators to be addressed by different committees and structures and processes that are in place. So for falls, we do get quarterly reports with a national benchmark. Our goal is always to outperform the mean of the national benchmark. The fall data is analyzed at our Nursing Quality Council. That's one of our shared decision-making councils, and it's made up of a nurse representative from each of the units. They're all direct care staff, and it's led by the direct care nurses as well. We kind of handle our smaller nursing units by pulling them together and call them multi-specialty. and have one nurse represent that. So we have a nurse from surgery, we have a nurse from med-surg, a nurse from birthing center, a nurse from the emergency department, and then one multi-specialty nurse that represents some of our smaller areas. For example, case management, infection prevention, cardiac rehab, things like that. And then I am their advisor to that council. So at they meet monthly, and at their monthly meetings they do, when the new reports are back, dig in and really analyze the reports that we're getting from NDNQI. They're looking at how we perform compared to our peers. They're looking at those process indicators as well to see how we're doing in identifying risk and putting interventions in place. The representatives also take the fall data back to the unit level, and the results are shared there. And that has been something that's been a big improvement for us in making and reducing falls, because staff are very much aware, very much in the loop. They know how many falls we're having. They take a lot more ownership in that. They often can tell you when the last fall was. So it's neat to see the staff being engaged, and really helps them having that data to be more engaged and take ownership. Next slide, please. In addition to looking at quarterly data and those benchmarked reports, we also analyze each patient fall to see how we can learn from it, how we can prevent it from happening in the future. So one way we do that is by a post-fall huddle. And so we require that before the end of the shift that the fall happened, that the on-duty staff gather and complete a post-fall huddle. We have kind of a worksheet to kind of guide that discussion, and I'll talk about that a little bit and give you a little more details about what they talk about and how we use that information. Our falls are also reported in our safety event portal, and so the event details would be routed appropriately for review and follow-up. So if the fall happened on med-surg, the medical surgical manager and the director are automatically notified. The manager of employee and patient safety is automatically notified. The chair of the Nursing Quality Council is automatically notified. So we get the information out there on a very timely basis so that review and analysis can be done. We also have the Nursing Quality Council do a nursing peer review when there's been a fall. There's other clinical things that might happen that we can request nursing peer review for, but fall is one thing we do ask them to look at. And they look through the record, the events, the post-fall huddle, and make recommendations on if there were things related to the nursing care that could have been improved, or if the care was appropriate. Or if it wasn't appropriate, they follow up with the manager of the department, and often it's an opportunity for some education. Next slide, please. So here's a little closer look at our post-fall huddle. The post-fall huddle worksheet helps collect some of the fall event details, and those fall event details then would be put into that portal safety event that they make, and it really is kind of structured around what are the things we need to know about the fall for reporting to NDNQI and other areas. At one point, we were also reporting our falls to Iowa Hospital Association, too, or the IHC. So it helps us get those details that we need right away, and so we don't have to go back and dig through the chart to find them. They also talk about what was the patient's fall risk before the fall. It has the staff look at contributing factors that might have contributed to the fall. Medications, were there medications that might have had some effects, some sedative effects or effects with orthostatic hypotension. They look at the physiologic, cognitive, and behavioral factors that were leading to, that might have contributed to it. Was the patient very confused? Were they impulsive? Were they agitated? What was their behavioral state? They look at environmental aspects. Was there something in the patient's environment? Was there stuff on the floor, or was the light, what was the lighting in the room, things like that that could have contributed, and also communication factors as well. We also have staff talk about the staffing for the shift. What was the staffing like? Did they felt like they had adequate resources? Was staffing at all a contributing factor? There's also a section on the worksheet for the group to really do some analysis and action planning. And what we ask is that the patient is included in that discussion. And so if maybe the patient got out of bed on their own, asking them, why did you get up? We might find out that they were concerned because they thought we didn't have enough staff and they didn't want to bother us. You know, what issues were there that led to the patient's action? We kind of follow a little root cause analysis, having the 5 whys built into the worksheet so that staff can kind of think through it to figure out what was the root cause. They document any countermeasures they've taken, and then an action plan for, they give suggestions for how could this have been, could be prevented in the future. And that staff input is really helpful. It's helpful to do that timely. Before we implemented the fall huddle, the staff would report the event in the event reporting portal. It would be routed to the appropriate people. I would look at it, others would look at it, and if we were missing information or didn't have a thorough enough analysis, you had to kind of go back and try to find the people that were involved, and it was really challenging to put all those pieces together once some time had elapsed. So doing the post-fall huddle right away helps us to really gather all that information and really be more focused on, you know, action planning to prevent it from happening in the future. Next slide, please. So here are some of the trends we started to notice in our review of falls. We saw that our injury falls were increasing, and of very much concern to us is that you can see we had a couple big spikes on the graph on the right where we had moderate or greater injury severity related to falls. So that was very concerning to us and really caused us to dig in and take a look at what was happening and how we might be able to make some improvements there. Next slide, please. So with the events with the moderate and severe injury, we pulled together the team that was involved, or staff that was on duty at that shift, and took the post-fall huddle and met with them and really did a even, you know, more of a deeper dig and a root cause analysis for each of those. And based on that, we developed some action plans and assigned out those action plans to appropriate people based on what we found out. That was very helpful, and some of what we learned and did from that we'll be discussing here in our future slides. The other thing that we did is the Nursing Quality Council did a historical analysis of all of our falls. So they built a spreadsheet, kind of threw in important details about every single fall, and really used that to analyze and to identify some commonalities. So it helped provide us some kind of priority areas to focus on. And that kind of leads us to our next slide, please. Through that analysis, we were really able to determine our typical faller at Waverly Health Center. So when we looked at all the falls, on average, the patient was 80 years old. They had a history of falls. They were scored as a high risk on the Morse Fall Scale. Our typical faller also had cognitive impairment. We looked at what times falls happened, and the majority of our falls were between 10 p.m. and 10 a.m., but then we had a spike between 4 a.m. I believe that should say 5 a.m. was the highest time. When we looked at our typical falls, most of our falls were unwitnessed and unassisted. Most of our fallers were on medications with a potential impact for a fall risk. And almost half of our falls were related to toileting, some aspect of toileting. And with our falls with the major injury, anticoagulation above therapeutic range was also noted for those with major injury. That seemed to be a common factor as well. So this kind of helped us look at what we really needed to focus on for our priority areas. For example, we felt like since most of our falls were unwitnessed and unassisted, if we could decrease our unassisted falls and have, if there was going to be a fall, if it was assisted, we were probably more likely to reduce injury. So that's kind of an example of how we used some of that information to kind of create a different focus. Next slide, please. So based on our review and our analysis, our two main goals were to reduce our unassisted falls per 1,000 patient days and outperform the national benchmark mean each quarter as we continued to monitor. We also wanted to reduce our injury falls to less than 0.5 per 1,000 patient days and continue to outperform the benchmark mean each quarter. So that kind of were the areas we were most focused on. Next slide, please. Some of our challenges were related to kind of four areas. One being patient condition. Some of the challenges from a patient perspective in relation to falls were patients with dementia or confusion or impulsivity. We also, through our root cause analysis, found that alarm fatigue was one of our challenges we faced. The staff were telling, in fact, I had one staff member say, I'll count to 10 when I hear a bed exit alarm or a personal alarm going off, because usually when I get down to the room, somebody's already taken care of it. It was a false alarm a lot of times. So we did work around looking at who was on an alarm. We did training related to how we could help prevent some of the false alarms too. So I'll talk a little bit more about that as we get into the presentation. The other thing was our staffing level. We had adjusted our base staffing level down to a lower patient daily census based on our trends for patient census. So when we'd experience times where we would get hit with a big influx of patients, so it was a little more challenging to adjust to that because we had less numbers of nurses and less people to call to work extra shifts, because some of them were working that shift or just got off the shift or working the next shift, so our pool was a little lower than what it had been in the past. Also, our layout of our unit can limit some of our visibility and can decrease or increase the staff response time to an alarm, a bed exit alarm or a personal alarm. Our hallway is basically one big long hallway with rooms all on one side, and they're single occupancy rooms, so they're kind of spread out down one long hallway. There's good things about that. It makes it very quiet and a very private environment, but it makes the real estate is a longer area to cover, and so it could increase some of our response time, and we couldn't directly see into many of the patient rooms. Next slide, please. So our action plan, we really took a different look at identifying fall risk. We felt like the number on the Morse scale wasn't as important when we looked at our analysis as some of the conditions of the patient related to their cognition, et cetera. So we found in research that there was a relationship between impulsivity and patient falls, and we really were able to confirm that through our analysis too. So that really gave us a new place to look at fall risk, that it needed to be more than just what the number was on the Morse scale. Next slide, please. we did develop an action plan related to alarm fatigue, and we tried to limit the use of alarms to only when necessary. In our Morse fall scale, depending on where you scored, at moderate or high risk, it would, give suggestions of alarms as an intervention. So rather than just focusing your assessment on if they need an alarm based on their score, it is based on criteria. And the criteria are listed on the slide there: cognitive impairment of the patient, impulsivity, if they have poor judgment, or extreme agitation. So those are the times we limit the use of alarms, because we found that there were some patients that were very high risk for fall, but they followed directions, they always called before they got up, they understood that, they didn't need an alarm. Those that were more impulsive and not likely to always remember to call were the patients we needed to limit alarms to. We also did work to train our nursing students and other clinical students, ancillary staff that are floating to the unit, to know how to suspend an alarm before they get a patient up. Because often, if they're going to be working with the patient, they might not always remember they had the alarm. They get the patient up, the alarm goes off unnecessarily, and that was kind of what we found. Those false alarms were causing people to kind of have to wait and see if it continued before they would respond to the alarm. So those were the actions we took to try to reduce some of the alarm fatigue. Next slide, please. Another action that we put in place was within arm's reach. And this was an idea through our searches of best practices. We found was in place through the Minnesota Hospital Association. Their health care engagement network, their first year there was focused on fall reduction. It was one of the strategies they had utilized. And so we decided to implement that. We tweaked it a little bit based on our analysis of a typical faller at Waverly Health Center again. And so within arm's reach, staff will remain with the patient within their reach of the patient anytime they're out of the bed or the chair, and that's including going to the bathroom. So the list of criteria for that would be patients that, again, those ones that need the alarms because they have cognitive impairment, they're impulsive, they have poor judgment or agitation, people with balance, gait impairment or dizziness, lower extremity weakness, if they had a fall within the last 3 months. Anticoagulation over therapeutic range was a criteria we added based on our analysis, and then over the age of 85. We added that because with arm's reach, even in the bathroom, because we'd have cases where falls where the patient was on the toilet, the nurse or aide was right outside the bathroom door to provide privacy, and the patient decided to try to get up, and before the nurse or aide could respond, had fallen. So that was a little bit of a concern for staff related to privacy of patients. We've addressed that we've given them some scripting about the importance of staying with them because of safety. So we've provided them with some kind of scripting that they can use related to the subject. And we just, really felt that safety trumped privacy at that point. The other concern staff has had is related to staffing, because if you're staying with a patient, often, they said they'd put the patient in the bathroom, they might go and be getting the medications ready or getting the bed set up, but if they have to stay in the room or in the bathroom with the patient, they aren't able to do other activities while they're waiting. And so they were concerned about staffing and having enough staff to be able to meet the needs of all the patients. So we have adjusted our acuity system that they use, and consideration is given to patients within arm's reach and how that might adjust our needs for more assistance. So next slide, please. We also had developed action planning around safety and surveillance. And we amended our hourly rounding process to add, we follow the 4 Ps. We added an S to that end for a safety check. So the 4 Ps, the S now isn't necessarily just plural, it means safety. So as part of the hourly rounding, we amended the process that alarms are verified if they are appropriate to be on. They're verified, and this is done even if the patient is sleeping to check to ensure the alarms are appropriately set. We, at times, had falls that were related to maybe someone had gotten the patient up, got them back to bed, but forgot to re-alarm the bed or re-alarm the personal alarm if they were in the chair. So this is kind of a way just to kind of do another verification on your hourly round. We also have the ability to kind of be more of a spotter now by utilizing, we just recently implemented a different call light system that helps make fall risk a little more visual. So patients at risk for fall have a yellow light, indicator light lit above their door, and it stays lit the whole time. And then patients that are at fall risk but also have those behavioral characteristics that, they're cognitively impaired, they're impulsive, we also put a red light on as well. So they have a yellow light and a red light for that kind of that behavioral risk for fall. So we're just newly implementing our system, but what we're hoping that will help is if we have maybe a busy shift and we have somebody come up from another unit to kind of help with answering call lights and such, we can alert them that, those patients with yellow and red lights are at the highest risk for fall, visually make rounds on them, more frequently, even every 15 minutes if you're able to, just so we have ability to kind of keep a better eye and be able to intervene and check on them more frequently to prevent them from getting up. Next slide, please. So here you can kind of see a look. Like I said, we're kind of early in our journey, so I only had 1 quarter of data back post-implementation of all the aspects that we've implemented, and we did reduce our falls. We didn't have any falls that quarter, so that was good to see, and we're continuing to monitor that. I do believe we maybe had 1 fall in the first quarter, but there was not injury associated with it, so that was good to see. On the next slides, I think I have the next slide. I have references, so I'm thinking maybe the slides will be sent out, so if you want to see some of the references, go to some of the information that we used in some of our action planning. It's there for you, and I'm happy to take any questions that maybe have come in.
All right, thank you, Kathy. That was wonderful. I am going to go ahead and unmute everybody's lines. We do not have any questions in the chat box at this moment, but everyone's lines are unmuted. So if you have a question, please ask, or a comment or feedback or anything you would like to join in at this time. Remember, we want to make this as interactive as possible so we can all learn from each other.
Hi, Kathy. This is Jody Atkinson from Clinton. Thanks. That was a really good presentation.
Well, thank you, Jody.
Yeah, you guys have had great luck here this last quarter. My question is about your acuity level and your staffing ratios. How hard was that to get that switched? We're kind of like a mirror. Our programs are very similar. Uh-oh, I hear music.
Somebody go on hold, must have, I wonder.
Okay. Our programs are really similar in patient safety, and we've just had a hard time getting staffing adjusted. And how did you go about that with the leadership there?
If you have your line on hold, can you please undo the hold button? We're hearing your music.
That's better.
Okay. There you go.
Our acuity system is based on patient characteristics. They're scored, and so being at within arm's reach scores them a little higher, and so that would, you know, as you throw all those patients in the mix, would increase the number, which would indicate a need for more staff. So that's how they've adjusted that. That being said, because we have adjusted our base staffing down, when we have those times where we have lots of patients, it's really challenging. And there's been shifts where, you know, yeah, it called for this, but this is what we had on duty.
Okay. Okay, good. Thank you.
There's probably been shifts that almost every single patient has been within arm's reach. To be honest with you, sometimes,
we have about 80% of our med-surg patients and PCU patients really at a high fall risk, and they are within arm's reach, and most of them are alarms as well. So I feel your pain.
Yeah. We do not typically use sitters or have the telesitting at all. There have been at times we've, you know, asked the staff to sit, or if we have, you know, someone available from another unit that can help us out, but we don't have, you know, a job role for sitters.
I like your deeper dive analysis too into your typical faller. That's a great thing, I think. Really hones in on your type of folks that you get there. We just did that recently in the ED too, and found that our average age faller there was about 50 and had behavioral health and attention-seeking tendencies. Some had a little bit of cognitive impairment, but that was very interesting. So it really helped. It helped us as well. So that was great.
In our emergency department and our ambulatory clinics and outpatient areas, our falls have been very, very low, luckily. So we haven't, you know, the dive we did was our med-surg area, was our problem area, our inpatient area. So, but I could see where that's replicating that would be very helpful, because it does kind of point to a focus, and it helps you really identify where to start.
Right, right.
Are there any other questions for Kathy? All right, well, Kathy, thank you so much for sharing your organization's story. I know you had a lot of great information in there, and hopefully it will be helpful to others. And we will be sending the slides out via email so you guys can have access to that reference list. If you have any additional questions, you can email Jennifer Creekmer at IHC, or I'm sure Kathy would be all right to take email questions as well.
Certainly.
So just let us know. And thank you, everyone, for joining us, and have a great afternoon.
Thank you very much.
Do you want to leave us?